Hi, I'm Inga Lennes. I'm the Senior Vice President for Practice Improvement and the Patient Experience and a physician in the MGPO. And I am here with Dr. Erica Shenoy, who is our Associate Chief of Infection Control, to talk about the preparation that's going forward in the institution for COVID-19. So, Erica, thank you for joining us today.
You be here.
The first question I have is, what are some of the important things that our physicians should know about what's going on around the hospital to prepare for this?
Okay, so hopefully some of you were able to see the town hall, and if you weren't, I think it's worthwhile on your T or somewhere just to review that, because we went through a lot of the information that I'll just briefly summarize here. So first of all, MGH for many years has been preparing for all sorts of events, including biothreats types of events, pandemic, influenza. So we have a group that's been working for many years. We have in the last several years, because we're designated as an Ebola and other special pathogens treatment center, and there's only 10 in the country, been really working very hard to prepare and have all the systems in place that allow us to respond as a hospital, also all of our ambulatory areas, and basically the part of the enterprise of partners as well. So we've been working on that. Many things are happening. I think our focus here today is to let you know what tools are available to you, because I know that you're getting lots of calls, your practice are getting lots of calls, patients, worried patients, some of them within there may have relevant exposure histories, either travel or otherwise, so we're going to go through those. Also, your front desk staff is doing amazing jobs even before your patients arrive of getting travel and symptom history. So they're going to be presenting you with information, and you need to know what to do with it, who to call, when to call them. So we're going to go through all of that today.
Great. Before we start, where is the one place where we can find this information in an up-to-date way?
Yes, so it's Apollo, and I will be the first to admit that I used to only go there for the menu at Eat Street and Blossom Street, but here's where you get to it. You do either your Partners P, but if you've upgraded to the XP, you go into the XP window, you look under Partners Utilities, it's alphabetical, MGH Apollo. When you click on that, Apollo will open. We have a yellow banner at the top that says coronavirus information. Click here, you will get the coronavirus page. Very important for this kind, there's FAQs, there's all sorts of things, but for what we're talking about today, on the left-hand side, it says ambulatory resources. You click on ambulatory resources, and what we'll go through is your clinical process flow. So other people in the entity, front desk staff, others are doing their own flows, but when it gets to you, it's the clinical process flow.
Great. So I thought today maybe we could do some scenarios. We could walk through some possible scenarios. So let's start with the patient that arrives at the front desk and meets criteria through screening with either with a travel history and cough and fever, is masked by the front desk, and then in the front desk workflow, a clinician is paged.
Yes.
So let's take over from that scenario and tell us a little bit about the workflow.
Okay, so what the travel screener is right now is 5 countries where there's ongoing transmission and the fever cough. And they're asking people, have you traveled to any of these areas in the last 30 days, yes or no? If the answer is yes, they get a mask. They also ask about the fever cough, and they're already masked, so we're all set with that. So what we need at this point is additional information, because as you know, these are very non-specific symptoms, and if you traveled somewhere 2 months ago, or actually on the borderline of 30 days, I should say, it may not be relevant. So we need you to get information from that patient. The clinical staff are instructed to put the patient in a room, get the phone number so that you can call in, and that way you can get most of the information you'll need telephonically. We have a tool that links directly from that workflow that actually asks you the questions. It asks very specific questions. Where did they travel? What date did they return? What date did the symptoms start? A little bit about those symptoms. Are they on an antipyretic or not? Have they had a close contact with a known case? That's actually one of the exposures. And then we ask for some information about where they're living currently. That's important, I'll tell you why. And a phone number to reach them, so that if you've gathered this information now and you're going to call, for example, the biothreats pager, because you have a symptomatic patient with a relevant travel history or exposure history, the biothreats pager, MD phone pager is listed. You page them and you're giving them all the information they need to help you sort it out. That pager is staffed 24/7. It's meant to be called when you have this information. It's very important that you get that information so that we can make a decision. You will get a call back within 10 minutes. It says in the paging directory, if you do not hear back within 10 minutes, because say someone's driving, or you call me or you call Paul Bittinger, our phone numbers are there so you can do that. We're going to walk through it with you, and usually if you've gathered all the information we need, we can make a decision right there. So what's our decision? We're looking to see if what you've gathered helps us decide if by the CDC criteria, this person needs COVID testing. That's what we're trying to figure out. If it's borderline, because things are changing, and if you saw the town hall, we're on our third iteration of what the CDC is considering a definition. The biothreats pager MDs are aware of those nuances, and we will then have to call the state epidemiologist, and that can take a little bit of time to get that information back. But while the patient is there, the biothreats pager person will give you some information. If they're clinically stable, they can remain in that room while we gather more information. So that's what you do for probably what many of us are most worried about, which is symptomatic travel history, in your clinic at that moment.
Great. So how about we go over the patient that is asymptomatic?
Yeah.
Is there any differences to the workflow then?
There's differences, but I do want to come back one thing. What if the patient in the room is not looking well?
Right.
Right?
Yes.
So like this is even more of a concern. Like they're not looking too good. They're a little diaphoretic. You're worried about them clinically, and we have to remember there have been 2 cases as of this morning diagnosed in Massachusetts of COVID. So statistically that patient probably has something else, and we don't want to limit care to that patient. So in areas, they're tier 1, I think is what you call it, the PPE, the personal protective equipment, is there for providers who've received training. And just a bit about the PPE. So if you've placed the patient in a room, most of us don't have airborne infection isolation rooms. If you put them in a regular room and they remain masked, they're contained. Their respiratory droplets are contained, and healthcare providers wearing the appropriate PPE, which is the gowns and gloves that you're used to, the N95 respirator, and the face shield, can interact with the patient. They should only do so if they've been designated by their group as the people who are going to interact. And obviously you're communicating that to the biothreats pager, and if we need to, we will dedicate resources to come help you in that unusual situation, but we can certainly help with that. If you don't have any PPE present, you need to have already called you're called biothreats, and we're coming to figure out a way to support you there. So that would be kind of more of the extreme situation, which I have to tell you, I've been staffing this biothreats pager a lot, and that has not happened yet. And we're getting lots and lots of calls every day, so we're hearing everything, and that has not yet happened, but we still have to be prepared for it. So let's go back, asymptomatic. Okay, so why are we masking these asymptomatic people? There is the possibility that someone who has a relevant exposure doesn't show symptoms. So at an abundance of caution, and I would say we're not aligned with the CDC here because we're even more conservative than the CDC here. We are masking those patients because we're bringing them into it. They're in a healthcare setting. We put the surgical mask on them. For the first thing you want to do is figure out, if they've traveled, do they really need the appointment today? So if they came for their annual and they traveled to Italy, they got back 3 days ago. As unfortunate as it is, you can try to figure out if they could defer their visit, and we'll reschedule you 2 weeks from now. I know you guys have some language on how to have that conversation. I think most patients will understand why you're doing it and if you say it in the right way. So if you can defer the visit, that is ideal.
Yes. Let me add that the patient experience team has worked on scripting for when we have to have difficult conversations with patients about delaying or deferring care, and we will send out links to that scripting if it's helpful to the practices. The other issue, I think, is identifying those patients ahead of time. So we are working with ambulatory management and the practice staff to be able to start to look ahead and use technology to be able to contact patients who might have care that we can defer. Certainly we would have to do that if we had a large surge of more clinically significant urgent patients that we had to see. So there's lots of behind the scenes works that are looking into how we can free up scheduled time to see patients who are more ill if we have to in the future.
Okay, so say the visit is going to happen, they're asymptomatic, they're masked, they need simple phlebotomy or something else, they have no symptoms, they can proceed with that visit. If during the visit a procedure is going to be performed, and I'm an ID, we don't perform a lot of procedures, so I can't really speak to what it's going to be, but I can tell you that if the procedure is going to involve an aerosol generating, so upper endoscopy, I don't know, looking in someone's throat, lots of things could generate aerosols that would be in a private office, and I'm just thinking those are the ones that you need to think ahead and say, even though they're asymptomatic, we are going to institute specific isolation for those procedures on the very small possibility that they've got virus, and in the act of generating aerosols, you could have those aerosols kind of enter into the air and cause problems. So that should be even like a smaller portion, because how many of those are really essential? We should try to defer those. If that's going to happen, you call BioThreats pager, and we are going to walk through how we're going to do it and help you through that. If it's a non-aerosol generating procedure, call infection control. So I've just told you, up until now, you've basically been calling BioThreats for like the higher level type of decisions and recommendations, and calling with state epi. For case-by-case infection control decisions around procedures that might happen in the office setting that don't generate aerosols, infection control nurses are available to you to answer those questions. If you think that the patient needs to be admitted, so it's a minor procedure but they need to be admitted, that's also a reason to call infection control. So we can figure out what we need to do on the inpatient setting. Again, they're asymptomatic, but they have a potential risk.
Great. Well, it sounds like we covered a number of scenarios.
Yes.
I can't think of many outside of this in terms of patients who flow in through the ambulatory clinics.
Mm-hmm.
We will link to not only the Apollo website, where you can find all of the workflows that Erica mentioned today, but you will see in the email that accompanies this Two Things video a link to the tool that can be used for gathering information from patients when you're called in the clinic, as well as a link to the tip sheet and how to use the Epic Travel Navigator. So those are some of the tools that were referenced today. You can find all of this information, as Dr. Shenoy mentioned, on the Apollo website, and the BioThreats pager is available for those more in-depth questions, especially around planned procedures. So I want to thank Dr. Shenoy for being with us today to recap this lengthy topic, which she summarized a whole hour's worth of content into 3 minutes. So I appreciate that, and be in touch if you are concerned.